I just wanted to take a minute to say that it really is an honor to be here. For many years, starting as I was a postdoc, I think I came as a volunteer, and then I coordinated the volunteers, so I know what you're all doing. And then I was a co-director 1 year, and so it's such a wonderful opportunity to come today to be able to actually share my research. And this may actually be the first time I see the whole conference in its entirety, because usually I'm running around like a crazy person behind the scenes doing lots of things. So I would really first like to just thank Emily Ansell for inviting me, Seth Axelrod, and Perry Hoffman. It's been such an amazing part of my career to be a part of this conference, and it really feels like coming home to speak to you about my research. So what I am going to talk about today is the impact of interpersonal processes on suicidal behavior in borderline personality disorder. What I want to do is I always like to give a roadmap of what I'm going to talk about. Emily asked me, because I am the first presenter of the day, and because one of the really wonderful and unique things about this conference is the mixture of audience members today. We have a wonderful mix of mental health professionals, nurses, social workers, psychologists, psychiatrists, but we also have family members who have loved ones who have been diagnosed with borderline personality disorder either for many years or more recently, and we also have consumers or individuals who have also been diagnosed. And so what I want to do first is just take a minute to do a little bit of an overview so that we're all on the same page in terms of what the criteria are, the prevalence of BPD. Then I'm going to talk about the prevalence and define suicidal behavior for us, so that we're on the same page. And oftentimes, I really want to clarify self-injurious behavior from suicidal behavior too, which most of the presentations today will focus on suicidal behavior, and then the connections between suicidal behavior and BPD. And then finally, I'll get to some 3 studies that I've been fortunate to be involved in, looking at interpersonal processes and suicidal behavior, and I always like to kind of bring it back home at the end with some treatment implications. So the Diagnostic and Statistical Manual, which is our diagnostic Bible of sorts in the mental health profession, defines BPD as a pervasive pattern of instability of interpersonal relationships, self-image and affects, and marked impulsivity beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following. So on this slide, you see the 9 main criteria for BPD. Frantic efforts to avoid real or imagined abandonment, a pattern of unstable and intense interpersonal relationships, identity disturbance, impulsivity, recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior, which is going to be the prime focus of the conference today, affective instability due to a marked reactivity of mood, chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger, and transient stress-related paranoid ideation or severe dissociative symptoms. So you can see a lot of criteria, and you need to have 5 of the criteria in order to meet the threshold for the diagnosis. So you can see that it really is a very heterogeneous diagnosis. What this means is that 2 individuals could have a diagnosis of BPD and have a very different symptom profile, and that's always something I think that's important to keep in mind. In fact, a number that I saw once that Marcia Linehan had written about was that there are actually 256 different combinations to meet criteria for BPD. So, we talk about this overarching disorder, but it's really important to remember that there are individual differences in how the symptom patterns play out and how the 2 individuals can have the same diagnosis but yet present very differently. And as treatment providers, that's very important for us to always keep in mind. Research, of course, we like to distill things down from 9. We like to have, parsimony and to keep things streamlined. And so we find that there are 3 major kind of clusters of the symptoms: unstable relationships, affective dysregulation, and impulsivity. And I'm going to be talking about all 3 of these major clusters today because they do all connect to increased suicidal behavior in BPD. So how common is BPD? We can see that it's typically 1 to 2% of the general population. In clinical studies, we find that percentage goes up, about 10% of outpatients and 20% of inpatients. So again, This is why we're here. This is an important disorder that deserves our attention, that deserves the funding, as Emily and as Seth and as Perry have commented, that this really deserves our attention and deserves the money in order to develop treatments. So suicide. So just to give us an anchoring definition for today, suicide is defined as the act or an instance of taking one's own life voluntarily and intentionally. One thing as mental health professionals that we often start many of our clinical interviews with, I know that I do, it's one of the first things that not one of the first things, but in that first initial meeting, that it's essential to ask about suicidal thoughts or ideation, okay? This is, thinking about or planning to engage in behaviors to end one's own life, because oftentimes the suicidal ideation will lead to suicidal behaviors. And so it's one of those essential components of that initial interview that we have to ask, and sometimes, I think as Seth commented a little bit, sometimes we're hesitant as professionals to ask, or we don't jump in there, and unfortunately, that does a disservice to our clients. We have to be able to ask the question. Suicide is one of the top 5 causes of death for individuals between the ages of 5 and 44. And completed suicides account for roughly 38,000 deaths per year in the United States. But the number of attempts, or non-completers as they're called in the literature, is actually much higher and can range from 4 to 200 times higher. Now, these statistics that you have are from 2012. And a couple of weeks ago, I woke to an article in the New York Times. So this slide is not in your program, and I apologize, but I thought it was important for us to really get the updated statistics. The headline from the New York Times was, U.S. suicide rate surges to a 30-year high. And that was really striking to me, and something that I really felt like we wanted to highlight. So this was a National Center for Health Statistics report tracking suicide rate from 1999 to 2014. And we see that right now it's the highest it's been, the suicide rate in the United States is the highest it's been since 1986. 13 completed suicides per 100,000 people. And in fact, it was the very staggering number of 42,773 people died from suicide in 2014. One of the statistics that really jumped out to me that I thought was also particularly relevant for today was the high jump in suicide rate for middle-aged women, ages 45 to 64, as well as for girls, ages 10 to 14. We know that, while men are diagnosed with borderline personality disorder, it tends to be more prevalent in females. And to me, this rate really stood out. And what was really sobering to me was the girls' ages between 10 and 14, that in fact that suicide rate from 1999 to 2014 had jumped 200%. And so that really sat with me as a human individual and as a treatment provider, that this really is something that we need to be aware of and we need to be assessing earlier and looking for these risk factors. So we know that clinical populations are at risk for elevated rates of suicide, and this is clinical populations across the spectrum, so major depressive disorder, bipolar disorder, schizophrenia, and personality disorders, and that individuals with a prior history of suicide attempts are more likely to make a subsequent attempt than those with no attempt history. But I would caution us to not just look at individuals with an attempt history, right? We have to also be aware that sometimes individuals will commit suicide even if they don't have that history, but it's always good to keep in mind the risk associated there. And I just want to remind us that one of the major criteria for BPD is that recurrent suicidal behavior, gestures, or threats, right? So we're seeing the repeatedness as being something that's really important for us to keep in mind. One of the other pieces of that criteria is self-mutilating behavior, and we're not going to focus, or I'm not going to at least today, focus so much on self-mutilating or self-injurious behavior, but I just want to make sure that we can see that we talk a little bit about the distinction very quickly. So self-mutilating or self-injurious behavior is self-directed deliberate destruction or alteration of bodily tissue with the absence of suicidal intent. okay? So cutting, burning, and other behaviors, both suicidal behavior and self-injurious behavior are associated with the desire to alleviate suffering, to end distress, to end negative affect. But what we find is the intention is different. Remember that in suicidal behavior, the intent is to end life. With self-injurious behavior, the intent is not always to end life, though that can happen. Often, the lethality tends to be lower for self-injurious behavior than with suicidal behavior, but again, would just like to remind us that self-injurious behavior can also lead to a suicide either accidentally. And then frequency tends to be higher for self-injurious events. So in a sample of adult outpatients, we find that the mean lifetime number of self-injurious events averages around 156 versus mean lifetime suicide attempts around 2. Self-injurious behavior is a risk factor for subsequent suicidal behavior, and prior history of self-injury is one of the strongest predictors of future suicide attempts. So again, that's why it becomes incredibly important to assess both for suicidal ideation, self-injurious behavior, because this can then lead to subsequent suicidal behavior. So specifically with BPD, compared to other clinical groups, remember I said that having clinical groups are at an elevated risk for engaging in suicidal behavior. And compared to other clinical groups, those individuals with BPD have a higher number of lifetime suicide attempts. They have an earlier age of first suicide attempt, and the relative risk for suicide attempts ranges from 3 to 10 times higher. So again, it highlights for us why it's really important for this conference today to really be focusing in on assessing and treating BPD and specifically assessing for suicidality. Given this association between BPD and suicidal behavior, it's really unsurprising that research really has tried to focus on investigating the predictors of suicide attempts in this population. And specifically for my talk today, 2 of the major predictors of problems with affect regulation and problems with interpersonal functioning is where I'm going to spend most of my time today. Other talks will discuss other predictors that are associated with suicidal behavior in BPD. So 2 studies that really, for me, kind of laid the groundwork of the research that I'm going to present to you today was one study by Stringer and colleagues in 2013 that showed that individuals with high BPD traits who also reported greater difficulty with management of anger and aggressive behaviors were at increased risk for repeated suicide attempts. Following up, Yen and colleagues also found that suicidal adolescents diagnosed with BPD were rated as having more anger and hostility than their non-BPD counterparts. Now, what was interesting was that Yen and colleagues also found that problems with affect regulation characterized all of the suicidal subjects in their study, regardless of BPD diagnosis, which really led to me and my colleagues wondering whether impairments in affect regulation and interpersonal functioning were risk factors for suicidal behavior across all clinical groups, or was there something more specific to BPD? And also that there was this research showed this greater likelihood of suicidal crises being preceded by an interpersonal trigger. And I started to wonder what could these types of interpersonal triggers be? What is it about the interpersonal world that could then lead to these suicidal crises? So this really leads us to the first study that I'm going to talk about, looking at chronicity of suicidal behavior in individuals with BPD, and specifically impairments in object relations. So, what are object relations? One of the things that I always think about with psychology or psychological theories in general is that we really like our jargon. We really like to object relations. It's really not always what it sounds like it, should be. And so I wanted to just kind of step back and talk about that because it really is the groundwork for a lot of what I'm going to talk about today. So object relations is really simply a template for how we view ourselves and other people. And I want to encourage us to think about when we see the word object, we want to kind of replace it with person or people, okay? This can be an actual person, it can be fantasy, it can be an image, it can be an internal model of somebody. It really is, object, again, that jargony word of why in the world would psychoanalytic theorists want to call people objects? We should go back and ask them all, but that's where we're at. So really want to think about this template for how we view ourselves and other people. It's really how do we organize information that we're taking in all of the time about ourselves, about the people around us, about our significant others, about our friends, our family. And it is, in fact, it is based a lot on our developmental experiences. We start to develop our object relations from very early on in childhood through our interactions with our caregivers, our interactions with our playmates, our object relational world, our people world starts to get populated. It really is about this cast of characters that we have in our everyday lives and the cast of characters that we have in our minds. We have representations and we have images of the important people to us. And so it really is kind of how we think about and how we organize our interpersonal and our social world. And because of this, it includes two major components, which I'll be focusing in a lot on today, which is the cognitive component, which is really how we think about ourselves and how we think about other people, and the affective component, how we feel about ourselves and how we feel about other people. And so there's a long line of research that says when we have adaptive object relations, we have relatively stable and consistent views of ourselves and of other people, which makes it easier for us to tolerate negative affect, and it makes it easier for us to tolerate negative interpersonal experiences. So an example of that would be, I have a relatively stable sense of myself as a good researcher, good psychologist, someone who's fairly extroverted that could stand up here today and give a talk to an auditorium full of people about my research. And so this is a fairly consistent self-view and stable image that I have. If today goes really badly, and tonight at dinner, Emily says, that talk, was a little confusing, no one could really follow you, I'm gonna feel bad, right? I'm gonna have an increase in negative affect. I'm gonna feel maybe embarrassed, I'm gonna feel sad, I might be angry at myself, I might get a little angry at Emily for giving me that feedback tonight at dinner and not just letting me enjoy it. And so I'm gonna, so there's gonna be a lot of negative affect, and that's gonna be a negative interpersonal experience between Emily and I for tonight. With adaptive object relations, if my view of myself and my view of Emily is fairly stable and consistent, I'm gonna bounce back from that. Maybe by the time I get back to Brooklyn tonight, maybe tomorrow, it'll take me, through Sunday, but I'm gonna bounce back, and my relationship with Emily will bounce back, okay? If I have more impaired object relations, that means that I have a lot more fluctuations in how I view myself and how I view other people. And so getting that feedback, having that negative interpersonal interaction, having that increase in negative affect is actually gonna be much harder for me to tolerate, and it's gonna maybe shift and shake how I feel about myself and how I feel about Emily. And I may not be able to recover as quickly from that. And we know that individuals who are diagnosed with BPD struggle with that. They struggle with the view of themselves of being fluctuating more, that it makes it harder to tolerate that negative affect, that increase in negative affect. It makes it harder to tolerate those negative interpersonal experiences. And so I think that's why it's really important for us to think about how these object relations, impaired object relations, fluctuations in how we view ourselves and view other people could lead to suicidal behavior in BPD. In general, we know that there is a link between impairments in object relations and vulnerability for suicidal behavior in a long line of empirical studies. Two that I'm going to focus on is Twomey and colleagues in 2000 found the internal beliefs that other people can't be trusted was associated with increased suicidal behavior. So again, thinking about that, if you feel that the world is unsafe, people can't be trusted, leading to more crises, more suicidal behavior. This is not with BPD diagnosis in there yet. This is just in general, that if you have more fluctuations in how you view yourself and others, and you have this more belief that other people can't be trusted or the world isn't safe, this is increased suicidal behavior. Kaslow et al. Found that patients hospitalized following a suicide attempt reported increased negative views of themselves and other people, lower emotional investment in their relationships, so this is lower compassion and care in relationships, and lower complexity in how they describe themselves and other people. So here, complexity refers to, do you have a kind of nuanced image? Are you able to kind of have empathy for yourself, empathy for others, perspective taking for self and others? What we found when we were doing the literature review is that we know that there's a link between BPD and suicidal behavior. We know that there is a link between impaired object relations and suicidal behavior. And we know that there's a link between impaired object relations and BPD. But no study had actually put them all together. And so that's really, for this first study, what we wanted to do. We wanted to look at the impact of object relational impairment on suicidal patients that were diagnosed with BPD. And we hypothesized that the quality of object relations, either adaptive or impaired, would in fact interact with BPD diagnosis to predict chronicity of suicidal behavior. And specifically, that chronicity of suicidal behavior would be highest in subjects with greater impairments in object relations who were also diagnosed with BPD. So I was very fortunate to have colleagues who were working at the Austin Riggs Center, which is in northern Massachusetts. And we had 131 subjects. This was data taken from the states of mind preceding a near-lethal suicide attempt. With the principal investigator was Dr. Jane Tillman at Austin Riggs. All of our participants resided at Austin Riggs, which is an intensive residential treatment facility. And the average length of stay for our participants from admission to study participation, so this, they may have continued to stay at Austin Riggs beyond, but was 22 weeks from admission to study participation. We did exclude anyone who had a suicide attempt while they were admitted to Austin Riggs, and anyone who had a diagnosis of psychosis or schizophrenia. You can see mostly female sample, mean age around 33, primarily Caucasian, some college education, and we did have 54% of the sample with prior suicide attempts. So 71 of the participants had prior suicide attempts, and the number of prior suicide attempts ranged from 1 attempt to 12 attempts. Just a little bit of diagnostic information. I'm not going to go too much into this other than to say that there were 29 patients diagnosed with BPD, and that suicide attempters were more likely to be diagnosed with BPD in this sample than any other diagnosis. So how do we assess object relations? It's not that easy, it turns out. It's not as simple as being able to give a self-report measure. God, I love it when we can do that. It makes it so much easier. This is a little bit more of a labor of love to assess object relations. We do what's called the Social Cognition and Object Relations Scale. It's a rating scale that gets applied to stories, and in this case, stories that participants tell. And in this case, we used the Thematic Apperception Test, or the TAT test, which is a series of cards. And on the cards, you see, some sort of scene that often is one person or more than one person. And the idea here is we ask the participant or a client or consumer to tell us a story about this scene that's being depicted on the card. The idea here is we prompt for thoughts, for wishes, and for the feelings of the characters. This lets us really get at the kind of unconscious or out of awareness ideas that we have about ourselves and about other people. And so you can see on the, if I don't mess this up, you can see one of the example TAT cards that we used in the study. And so what you do is you would ask the participant to tell a story about the card. So, my story might be that, here's a woman, she's on the floor, she maybe has received some, upset or distraught news about a loved one. So you're already seeing my object relations, right? A young woman, distraught news. And so, and that she's, very worried about what's going to happen, okay? So that would be my kind of object relational story here to the TAT card. And it's out of, and what happens is with these stories, we have a team of raters or coders who then go through and assess for object relations using different scales. And so remember I said before that we have both the affective and the cognitive components that we're looking at, okay? The affective scales include things, how do we manage aggression, right? So in my story that I told you, there was no aggression. So either I'm really good at managing aggression or perhaps I'm denying aggression, right? Because there was an absence of any kind of aggression in my story. Affective quality, right? I had sad, I had upset, I had distraught. Emotional investment in values, this is kind of compassion and appreciation for interpersonal values and relationships, self-esteem, stability of self-concept, caring, commitment, and engagement. Those are the affective themes that we're looking for. And so someone could take my story and rate it for my affective object relational quality. On the flip side, we can also look at how do I think about myself? How do I think about other people? And look at the cognitive scales. So these are things like how do I understand social causality? Can I understand what's the causal links between motivations, feelings, and behaviors? Remember from my story, I said that she had received some bad news and was feeling upset. So that would be the causal link. There was some kind of cognitive process or complexity to the story. And then complex representations of people, perspective-taking, empathy, understanding, and understanding the motivations of self and other people. And so we take these stories that participants tell us to the TAT cards, and we come up with ratings on affective and cognitive object relations. And we hypothesized that impairments or lower scores on both facets, both the affective quality and the cognitive quality of object relations, would lead to greater suicidal behavior in individuals with BPD. And we didn't find that for the first facet. So we first looked at the affective link. And so there was no significant relationship. So the quality of the affective interpersonal object relations did not interact with BPD diagnosis to predict lifetime suicide attempts. But what was interesting is that it was the cognitive facet. So how we think about ourselves and how we think about other people, the social causality, the ability to kind of link up kind of cause and effect, the ability to have perspective taking and empathy interacted with BPD diagnosis to predict lifetime suicide attempts. And so let's just look here so we can see that the effect of BPD diagnosis on suicide attempts is most pronounced, right? So this is lifetime suicide attempts going here, and the object relations, the cognitive, how we think about ourselves and other people down here. So you can see that BPD diagnosis was more pronounced at low or more impaired levels of the cognitive facet of object relations. So in other words, participants who were diagnosed with BPD in this study, as compared to those without BPD, which is this line, were more likely to have a greater number of past suicide attempts if they had impairments in the cognitive aspects, if they had more impairments in social causality, finding that cause and effect, finding that link, and also if they had more impairments in terms of perspective taking in their relationships and how they think about themselves, and empathy for themselves and other people. And so really what this started to suggest is that difficulties with perspective taking and understanding motivations, feelings, and behaviors is in fact important in this population and gives us a point of trying to intervene and trying to think through how can we assess for and how can we possibly prevent subsequent suicidal behavior. What we also saw was that impaired object relations was not just a general risk factor for suicidal behavior. So this line down here is relatively flat. It really was having the BPD diagnosis interacting with the impaired object relations on the cognitive aspects. It wasn't just a general risk factor in this sample. It was something specific to individuals diagnosed with BPD. On the flip side, one of the things I always like to think about is what are we striving for, right? What are we thinking about as mental health professionals? Where do we want to move our consumers and our clients to? And thinking about how adaptive object relations could really serve as a protective mechanism in this study. And so we were looking at BPD diagnosis, and as I said before, impulsivity is an important part of the symptom profile of BPD. And so we were wondering that if we didn't just look at the BPD diagnosis, but rather took a facet of the BPD diagnosis that we know is very much linked with suicidal behavior, impulsivity, if we would see the same relationship. And so impulsivity, is defined as the tendency to act on a whim with little or no reflection of consequences or consideration of consequences. We know that impulsivity is an important risk factor for suicidal behavior, and specifically what's called negative urgency, or impulsive behavior in the context of negative affect. Right, so high negative affect, we see more impulsivity, which then can lead to more suicidal crises. And we started to wonder, would the capacity to manage impulsivity, would that be related to how we view ourselves and other people? Could object relations impact that capacity to manage impulsive urges? If I have a stable sense of myself and a stable sense of other people, would that buffer me from having more suicidal crises or more suicidal behavior? So again, we wanted to look at that question. And we hypothesized that impaired object relational functioning would be associated with heightened risk for chronic suicidal behavior in highly impulsive individuals, but not for individuals that were low in impulsivity. And so we had the same participants that we used in study 1. So again, we used the same Austin-Riggs sample, but instead of looking at the BPD diagnosis, we were able to look at impulsivity as a continuous measure. So again, we use those TAT cards and the stories that were told and the codes to the affective and the cognitive object relations. And this time we used the Barrett Impulsiveness Scale, which had 3 subscales that we also looked at. So attentional impulsiveness, which is the capacity to maintain concentration and sustained focus, which if you have the attentional impulsiveness, you don't have the capacity to maintain concentration and sustained focus. Motor impulsiveness, or the tendency to engage in impulsive decision-making or unplanned action, and non-planning impulsiveness, which is the inability to plan and prepare for future events and the inability to consider cause and consequence. So one of the first things we wanted to do was to just see, were there any differences between individuals in our study who had a previous suicide attempt and those that had no history of suicide attempts in terms of impulsivity. And there were no significant differences in impulsivity between suicide attempters and non-attempters, which we were actually surprised about. This was an unexpected finding for us. Typically, research shows that there is a link between impulsivity and suicidal behavior and suicide attempts. So something maybe about our sample at Austin-Riggs, the same connection didn't hold. Their impulsivity on its own did not distinguish between those who made a suicide attempt and those who did not. But we do see something important happen again when we add in the object relations, when we add in how we view ourselves and other people. And so specifically, what we found was an interaction between the non-planning impulsiveness with impairment in managing aggressive impulses was predictive of lifetime suicide attempts. So remember that non-planning impulsivity is not being able to plan for the future, not considering cause and effect and how cause and effect go together, and that interacts with a poor ability to manage aggression and aggressive impulses to predict lifetime suicide attempts. And so we can see the relationship here. So the light green are participants. I guess it's not light green in your book, but light green here. high non-planning impulsivity were more likely to have higher numbers of past suicide attempts if they also demonstrated really significant impairments in managing aggressive impulses. -4 standard deviations below the mean was very low in terms of being able to manage aggressive impulses. This means that those stories that they were telling to the TAT cards were incredibly aggressive and had a lot of aggressive affect and difficulty kind of managing. It was really kind of coming out across all of the stories that they were telling to all of the different cards. And so, just to kind of put it all together for this particular study, no global differences in impulsivity levels between suicide attempters and non-attempters, which we didn't expect, and I think is an interesting area and potentially due to our restricted sample at Austin Riggs. But here we saw that individuals high in impulsivity, how they feel about themselves and how they feel about other people, this difficulty with managing those aggressive impulses, difficulties managing hostility, really leading to more increase in suicidal behavior. And so there was this interaction between non-planning impulsivity, the difficulties with planning for the future, difficulties anticipating cause and effect, leading to a greater number of lifetime suicide attempts. I think one of the really strengths of this particular study and why I wanted to highlight it is we often, we know that there was a link, right, between difficulties with hostility and anger leading to more suicidal behavior. But those studies were really done with those self-report measures, kind of checklists, and circle yes or no, or I'm on a scale of 1 to 5, how angry do I feel right now? And what I really like about this is, again, we're getting at that non-conscious, that out of our awareness feelings of anger and aggression. That, again, really points to the fact that it's incredibly important for us to do. So really quickly, since apparently I'm running out of time, I want to just really briefly go into a study that I'm really excited about because my work has primarily focused on understanding interpersonal functioning across different diagnostic groups. And so one of the things that I was really, the two studies with object relations really led me to think, what specifically are the interpersonal difficulties that are, that challenge our individuals, our patients that are diagnosed with BPD and lead to more suicidal crises? What are the interpersonal risk factors? Is there a particular interpersonal profile that we as treatment providers could really think about and think about how we could use treatment interventions to target these interpersonal processes? And so I'm actually going to just skip quickly, since I only have 15 minutes, and talk a little bit about the two theories of suicidal behaviors, two psychological theories of suicidal behaviors that have shaped my kind of interest in this question. So the escape theory by Baumeister, which describes kind of the failure to attain a standard or a goal as leading to kind of more suicidal behavior, suicidal crises, or unbearable negative self-awareness. And that this theory really focuses a lot on achievement and competence, and that difficulties in attaining kind of achievement and competence really leading then to suicidal behavior. On the flip side, Seth mentioned earlier Thomas Joyner's, the interpersonal psychological theory of suicide, and the idea of kind of thwarted belongingness or an unmet need to belong, and perceived burdensomeness or an unmet need for social competence. Kind of leading to, and so there's this intense desire to connect and to belong and to be engaged in interpersonal relationships, but feeling as though it's difficult to connect or can't connect, and that leads with acquired capability or an accumulation of adverse and painful experiences leads to an increase in suicidal behavior. And I think that that's a really important thing for us to keep in mind, this unmet need, this thwarted belongingness and perceived burdensomeness. And so the escape theory and the interpersonal psychological theory describe kind of two sets of needs. And I wanted to look at, what are the specific interpersonal problems that could, is it more about this escape theory, more about agency, more about control in relationships, or is it really more about this wanting to connect, wanting to belong, wanting to engage in relationships that really is what happens? And so this led me to do an interpersonal assessment. And so what is an interpersonal assessment? It's looking at the specific types of interpersonal problems. So what are the things that I have a difficult time doing in my relationships? What are the specific types of interpersonal sensitivities? So what frustrates me? What bothers me? What irritates me in my relationships with other people? And then what are the specific types of interpersonal values? What do I want in my relationships, right? And so for Kermit here, right, he values his friendships, he wants to be connected, he's sensitive to some of the controlling behaviors by some of his friends, and maybe he has problems telling some of his Muppet friends what his needs are in relationships. And so that really started to think, could we come up with an interpersonal profile that would characterize individuals who are high on BPD and high on suicidality? And could we link this interpersonal profile back to psychological theories of suicide, either the unmet need for belongingness versus the escape or the achievement, more achievement-related difficulties? So just really quickly, we did this in a non-clinical sample this time. So it was 129 undergraduate students from an urban multicultural university. I won't go through all the demographics in the interest of time, but 39.6% of our sample had reported that they had thought about or attempted to kill themselves in their lifetime. And that 4.3% reported that they had attempted suicide or intentionally self-harmed in the past year, which was very sobering for me. I'm also, in addition to being a researcher and a clinician, I'm a professor, and these are my students. And I teach Introduction to Psychology, and many of these students were my students when they participated in the study. And so that really kind of was very sobering to me as a professor. So we had 37 participants who were high on BPD features using the Personality Assessment Inventory and high on suicidal behavior. So what that meant was these were participants who were one standard deviation above the mean on BPD criteria, and who also endorsed that item that they thought about or attempted to kill themselves in the past year. And so, again, it's a very small sample, it's a non-clinical sample, but I think some interesting things kind of do emerge. And so what we found as a profile for these high BPD and high suicidality participants was that they had interpersonal problems related to being overly warm, overly nurturant in their relationships. And so what this meant was items here are, I put others' needs above mine too much. I try to please other people too much. I'm affected by another person's misery too much. So these are the problems that they're having in their relationships. They're irritated or frustrated or bothered by cold, remote, withdrawn behavior in other people. So this is something so important for us as family members, as friends, as treatment providers to keep in mind, okay? And that what they value, what they want in their relationship is they value being able to express themselves openly. They value being heard in their relationships with others. And so to me, what this said, this profile, and again, it's a very preliminary 37 participants non-clinical sample, but what this really said to me was this really looks a lot like that thwarted belongingness, that perceived burdensomeness that we were seeing in Joiner's theory, the psychological interpersonal theory. And that this really kind of gives us an interpersonal profile that we can work with in treatment as treatment providers, that these are the individuals who are high on BPD features and high on suicidal behavior. They want to feel as they can be open in their relationships, that they can relate to other people. They wish for this in their relationships. They get bothered by remoteness or pulling back behaviors. by other people, and that to compensate, they may end up engaging in very overly warm, overly nurturant, putting other people first too much, which could then be very problematic for them in their relationships. And so again, that kind of thwarted belongingness and perceived burdensomeness. Again, very small, non-clinical sample, but we are starting to collect this data at the Austin Riggs Center starting this summer. So we can kind of extend it then into the clinical population. So I think, in terms of concluding remarks, I really want to jump more ahead and jump to the treatment implications, because I think this is really where I want us to be thinking about how can we take this information from these studies and really think about treatment. So targeting views of how we view ourselves and how we view other people is incredibly important. We saw that how we think about and how we feel about ourselves and other people mattered in terms of predicting increased numbers of suicide attempts. And that adaptive object relations, relatively stable, consistent sense of self and others, was a protective mechanism in both study 1 and study 2, that there was less suicidal behavior. That improving perspective taking, improving and understanding social causality could really help individuals who are struggling with BPD and who are also struggling with suicidal behavior. So this leads me to think about mentalization-based interventions, a la Peter Fonagy and Anthony Bateman's work. The interpersonal profile also kind of reminded me of being able to target through interpersonal effectiveness in DBT, right? And increasing self-respect, increasing objective effectiveness, what's important in terms of maintaining relationships. That would really help us to target that interpersonal profile and address thwarted belongingness and perceived burdensomeness. And then finally, also reducing impulsivity and difficulties with managing aggression and anger. And again, I was brought back to DBT there as well with mindfulness, emotion regulation and distress tolerance. And so I would like to just acknowledge my collaborators as well as my research assistants. I can't do anything without my research assistants, so I just wanted to acknowledge them. Thank you.
Thank you very much, Nicole. That's really long. So we, if you have questions, you can turn that down a little bit. Are we good?
All right, so if you have questions, please pass them to the aisles on the note cards. People will bring them up. We'll take 1 or 2 questions, and then the rest of them we will do at the panel session later today. Thank you very much.
So Nicole, there we go. We had a question about the study looking at impulsivity and aggression. Were you able to distinguish between aggression toward the self, like self-loathing, versus aggression towards others? And if so, was aggression towards self more likely to predict number of lifetime suicide attempts?
Right. Unfortunately, we couldn't. I think it's a great question. What happens when we take those TAT cards is that aggression is just a global score. And so we're not able in that moment to tease apart what's the self, like self-directed aggression versus other-directed aggression. I think that would be a really wonderful thing if we could go back into the data and do that. It's just when we collapse it, it really kind of is just managing aggression in general rather than specific to self or to other, unfortunately.
Okay. There we go. One other question about the Austin Riggs sample that you had. Do you think there's any implication towards the, given that the Austin Riggs sample was probably very different in SES than some of your other samples, and do you think that explains any differences?
I do. I think it's something that, when we were thinking about the data and when we were writing up the papers in particular, that we really wanted to make sure that we addressed that as a limitation. This is not your usual sample of inpatients or outpatients even. And so I think some of the odd findings of impulsivity not predicting that impulsivity didn't distinguish between suicide attempters and non-attempters. I mean, where I went immediately was, this is the Austin-Riggs sample. They just may be less impulsive in general because they just have more resources. There's less going on. So I absolutely think so. I would love to get a broader clinical population that gets out of that limitation of SES.
Yeah. Well, thank you very much, Dr. Cain. We appreciate that. So let's give a round of applause for Dr. Cain.